Well, thank you very much. It's a pleasure for us here at NIH to talk to you today. We truly appreciate all the troubles that have occurred in the research enterprise over the last 9 months, and um, and certainly our uh, gratitude for the work you've done. And we'd like to talk a little bit now today about the actual science of COVID and its effects on the nervous system, behavior. And so we have 10 institutes here with issues related to COVID, and we're going to go through each of those one by one. So could I have my next slide, please? I just wanted to say by starting off that what we know is that COVID has, in the acute stage, significant problems that affect the nervous system, whether it's muscle, brain, nerve. Many of these are things that occur commonly in an ICU setting, such as delirium. Um, but could have potential long-term effects in people coming out, especially the elderly. Um, there are a couple of rare post-viral syndromes that have occurred. These are things like Guillain-Barré syndrome, very unusual acute necrotizing encephalopathy, um, multiple sclerosis-like issues, and stroke has been a big problem because of the hypercoagulability due to the COVID virus. Next slide. Um, the one big question is, what does the virus actually do in the brain? And this is still a little controversial. The previous slide, the groups from Germany looking at neuropathology have some evidence that the virus may be getting in through the olfactory nerves into the brain itself. But in actual fact, the titers that are found seem to be extremely low, and it's still, I think, controversial. So in this study, which was reported out of the New England Journal of Medicine last week from the NINDS investigators, they were not able to PCR virus out of the brain. But they do see multifocal areas of abnormalities, primarily characterized by breakdown of the blood-brain barrier and also infiltration in perivascular spaces by immune cells. Surprisingly, this study was done after MRI scanning the autopsied brains and going after areas that were abnormal on the MRI, and they did see kind of a high volume of lesions in the medulla and the brainstem, potentially related to some of the issues that have been reported in COVID, particularly this issue of folks having low oxygen levels, but no real sense of shortness of breath, and also problems with sleep. How these different areas of abnormality relate to clinical symptoms or the potential for long-term problems is really still yet to be understood. Next slide. What we do know is that there are persistent symptoms in many people who have been infected by the virus. So there are a number of studies from outside the US showing that a large proportion of patients, sometimes up to 50% of those who are hospitalized, will have persistent symptoms even 2 to 3 months later. And as this slide shows on the right, that there is disability in the sense of less ability to function in one's usual activities, more pain and discomfort, less mobility, and more anxiety and depression. You can see the type of symptoms that are reported. Fatigue is the big one, shortness of breath, joint, different types of pain syndromes, cough, loss of smell, um, headache, a lack of appetite, dizziness, myalgia, diarrhea in this report. Next slide. This is, as I mentioned, was hospitalized patients, but this study here from the CDC is in people who were never hospitalized, and there about 35% of them did not return to baseline 2 to 3 weeks after testing positive for the virus. And this contrasts what one would expect if it was influenza, where about 90% of people would have recovered by the 2-week period. And again, you can see the symptoms are very similar to what we saw before in the hospitalized patients. Fatigue is the big one: cough, headache, body aches, fever, chills, loss of taste and smell, congestion, shortness of breath, sore throat, chest pain, abdominal pain. Confusion is what they listed here. Most of the people we've talked to, it's not confusion as much, but it's trouble with memory, trouble with concentration, um, and often associated with the fatigue. So this is occurring even in people who are not hospitalized at a reasonable percentage. What we don't know is how long this lasts, how long it takes people to get better. From what we've heard from most doctors, that the patients, some of them are on a slow course of recovery, but no sense yet, at this point at least, that people have kind of hit the wall. But that's something that still has to be explored. Next slide. And so each of the institutes have their own special interests, and I'll talk to you about them. We put out supplements, competitive supplements to grants to do COVID research. The grant did not have to be about COVID, but the money was used to do COVID research. We set up for NINDS at NYU a data center to bring in reports of neurologic complications of COVID. And right now, NIH is working very hard to put out a research program to look at the post-acute COVID syndrome, the recovery process of COVID, where Congress has actually allocated $1.15 billion over the next 4 or 5 years to try and understand this better. I think that's my last slide. So I'd like to now turn it over to Dr. Nora Volkow from the National Institute of Drug Abuse.
Walter, thanks very much. And I appreciate the opportunity to speak to all of you about this extremely challenging area that we're facing, which is the question of the potential long-term effects of COVID on the nervous system. Can I have the first slide? But I'm going to be addressing it from the perspective now of those situations where it may be more silent, because to start with, it actually may take more years to manifest itself. And that relates to the very important question: if a mother who is pregnant, a woman that is pregnant, has COVID, is there any evidence that that could have deleterious effects to the newborn? And overall, the information seems to show that there is very little vertical transmission. Apparently, the placenta is pretty good at protecting the fetus from the viral entry. There's been isolated cases where there has been documentation of infection of the fetus, but they are very, very rare. On the other hand, this is the only way by which the virus could affect the fetus and could affect his or her brain. And as was mentioned just by Walter, the same pertains in this case. We do know that COVID produces major pathology in blood vessels, and that is one of the mechanisms by which you could disrupt brain function, but also it mounts a pretty significant inflammatory response. And that inflammatory response in and of itself could lead to changes in the brain, among other things, by disrupting blood-brain barrier, but also by attacking neurons and glial cells. We know from prior experiences, specifically the Spanish encephalitis, that it was associated with a higher incidence of schizophrenia, a prevalence of schizophrenia in the children born out of mothers who had been infected. That later research showed that it was related to the immune responses during the viral infection. And thus it becomes very important that we are prepared to follow up the outcomes of these infants as they grow up, but also importantly of children, as if they get infected, how this is ultimately affecting their brain. So the next slide. So one of the areas that the Institute has basically supplemented is to put supplement funds for a study that we are doing in partnership with the HEAL initiative and several institutes at the NIH, including NINDS, as well as NIMH and others, to actually monitor close to 7,000 newborns until age 10 periodically, to assess the effects of adverse environmental effects, such as opioid exposure during pregnancy. But this allows us to supplement and to start to look at the effects of COVID infection. And the images to the right just shows a pilot already documenting what may appear to be, it's very preliminary, slowing of myelination in 30 infants who were born of mothers who were infected with COVID. Now, this I just want to emphasize is very, very preliminary, but it does highlight that this is going to be very important for us to follow and take advantage of these studies. The next slide shows another study that we're also supplementing that is also evaluating brain development, but initiated in age 9 to 10 in 10,000 to close to 12,000 adolescents as children as they transition into young adulthood to evaluate, number one, if they get infected, how that affects their brain. But importantly, to the opportunity that we get of what are the consequences, the social consequences, and the interactions and economic disruptions that are produced by the epidemic in terms of brain development, the differences on the way that children and adolescents are learning to virtual technologies. Again, we're supplementing this study that now has been gathering data for close to 4 years. Finally, the next slide that I just want to highlight is that as an institute that is involved, of course, on drug abuse and addiction, and the effects of drugs on physiology, we're very concerned about the interactions that drugs, which affect multiple systems, but certainly the lungs, the heart, the immune system, the endocrinological system, all of which, as well as all of which are involved with COVID, may have in terms of outcomes for patients that have a substance use disorders. The next slide shows data from electronic health records that had evaluated the risk of becoming infected with COVID if you have a history of a substance use disorder, whether it is alcohol use disorder, AUD, cocaine use disorder, cannabis use disorder, opioid use disorder, or tobacco use disorder. Regardless of the type of substance use disorder, this study showed significant increases of risk, actually tenfold for those with an opioid use disorder. And if they do get infected, what this study is also showing, they are much more likely to die from COVID than if they do not have a history of substance use disorder, which are the results that you see to your right. Deaths of COVID-19, this was data up to May 2020 when the deaths from when you got COVID were higher. Now we do better. But it is differentiating death in African Americans, Blue versus death in Caucasians, and recognizing the much higher rates of death among those that are African Americans. In the middle is COVID plus substance use disorder, and you can see the pretty dramatic increase in mortality associated with this individual. And what is also very, very, very telling is that despite the strong effect that substance use disorder has on mortality, you can still see the negative impact of being an African American due to the very frequent comorbid conditions to which they suffer. So we are supplementing researchers to look into these interactions to try to understand better ways to prevent and treat both the COVID and the substance use disorder in these patients. And with that, I thank you for the opportunity to present the interest for the National Institutes on Drug Abuse.